hopefully these slides will just get us started, give you a little bit of an idea about SRM, and hopefully some of the, let me look here. I don't know why it's not wanting to advance my slides. Oh, there we go. Give you a little bit more information about us. So we really have a team approach. We are a larger clinic. We have multiple locations. We have an Everett location, a Kirkland location, Bellevue, Seattle, Tacoma, Spokane, and our whole goal is to really try to improve access to care. So we really, because of the fact that we're a larger clinic, we do always really work as a team, and each physician has a wonderful team that supports them in terms of nurses and medical assistants and financial counselors. We have mental health providers. We, have nutritionists that work with us. So we really try to all work together to offer the best care. And I think, at the first visit, my kind of thought is I really want to listen to the patient's story, to talk through all the information together. And I feel like our goal is to try to educate patients about their options, give input about what we think would be the best plan, and then most importantly, to support our patients through the journey. So a lot of patients, I think, well, what should I do in preparation? I know it's an hour visit. That's a long visit, and I love that because we typically have plenty of time to kind of work through things together. But I think some of the first things, just to make sure you get the most out of your visit, is double check on that appointment time and date. I think many of us at this point, obviously all of you here, have done Zoom before. It was totally newish to me about a year ago, and now it's I spend most of my life doing it, I think, day to day, and maybe practice in. And it's funny, I see this sometimes where I'll be at home checking an email and I'll see one of my patients is logged in and I have this panic of like, wait, when's the meeting? But I know they're practicing their login, which is great. And then, if you've not worked with Zoom before, just know a little bit about the troubleshooting. You don't have to be an expert by any means, none of us are. And write down your questions. It's really interesting. I feel like a lot of times patients almost say, well, I'm sorry, I have so many questions. And my response is always, I love a list of questions. I'm a list maker. I love to make a list for myself in my personal life and at work, keeps me organized. And I think when you have a list, then you really are going to get the most out of the visit. So we really think that that's a great idea to come with your list of questions, and we expect that, and we're really prepared to answer them. At the appointment, you're going to meet your doctor. It's a little different in that we're meeting through Zoom, but you will meet your doctor. The first thing we typically do is review the history form. There's a pretty long intake form. It is hefty. So, we have a lot of questions. We want to make sure that we ask all those important questions. So, definitely make sure you allow some time to fill that out. And then ideally it's sent us and scanned, so the physician also has time to review prior to the visit. And then at that time, we'll review history and any testing, any treatment you've had done so far. If you have had outside testing and it's been recent, typically within a year or so, we're happy to accept that testing. We don't need to recreate everything. A lot of providers do a really excellent job of getting things moving. So if there are outside tests, we often can have those scanned into our system as well, so we can review. So then we'll discuss, what diagnostic testing have you done? What do those results look like? What tests remain in terms of a proper fertility evaluation? And even sometimes the first visit, we start touching upon treatment options. We may still be in just gathering information phase if no testing's been done. There's also no pressure to come with testing. Many patients come without any testing so far, and we're happy to begin that process of organizing it. So we talk about the testing. We may touch upon treatment options. We'll review your next steps. Now that everything is kind of through Zoom, at the end of the first visit, I always, tell my patients, you'll be hearing from the nursing team. So one of the nurses will reach out. You'll be hearing from the financial counselor who can look at your plan and your insurance plan and learn more about your benefit. And often the schedulers will be touching base to help schedule some of the tests that we've likely talked about at that initial visit. So all those things are kind of what happened during that initial visit. So, in terms of some of the testing that we think about on the female side, so many times we will think about a pelvic ultrasound just to learn more about the ovarian and uterine anatomy. We'll talk about testing to check the fallopian tubes. There is a test called HSG, or hysterosalpingogram, that we often talk about if that hasn't been done yet. And this also gives us more information about the uterus. So a lot of times we're talking about blood work to learn more about hormonal things. We're talking about tests that give us more information about anatomy, like ultrasound and possibly that uterine tubal test. And then there's also like preconception things we talk about, just general health kind of things, checking antibodies for immune status, talking about genetic testing, and if a couple wants to do that kind of screening pre-pregnancy. And then for men, usually we start with just a semen analysis. That is almost always the first step. Again, if it has been done on the outside, we're happy to review it. Sometimes if the semen analysis comes back and there are more significant findings, we'll usually repeat it anyway as our next step, but sometimes we'll do hormonal testing for men. Sometimes we will also speak with our urology colleagues. So one of the nice things about SRM is there are 3 urology providers that work in tandem with us. So they are able to see patients at SRM. We are able to arrange consultations if it's a more complex urology issue. They do procedures at our surgery center. So it's nice that we have the ability to work closely with urology if needed, because we know when we find something with the testing, it can often be an even split between male and female factors. So it's nice that we have that support built in as well. So as I kind of touched upon, a lot of time, what's kind of happening now is I feel like the first visit obviously is our telemedicine visit. We go through the history, the journey so far, we talk about the testing. And then many times we can do almost all the diagnostic testing at one visit, where you can come to the SRM clinic of your choice. And usually that's the one that just is closest to you. And we do pelvic ultrasound at all of our locations, so that's usually pretty easy. It's almost always going to be a vaginal ultrasound, just so you're prepared. I think sometimes when there's a surprise and you're not expecting it to be vaginal, that can be a little overwhelming. We see best, we get the highest level of information with that approach, so that's almost always the kind of ultrasound we do. Now, if someone just can't tolerate a vaginal ultrasound, that's fine. We can also do an abdominal, but vaginal usually gives us the best information. There's the hysterosalpingogram, which is kind of this it's an x-ray where we're watching dye move through the reproductive tract. So it does involve placement of a speculum. We place a catheter in the cervix, the dye moves forward, and ideally out of both fallopian tubes. And we do take x-ray pictures as that is happening. That one we don't do at every location, only because it requires a really large room for the machine that takes the x-ray pictures. So Kirkland and Seattle and Tacoma, I think at this point are the locations where that is most commonly done. Blood work is often a combination of egg supply testing. We check closely upon the thyroid and other hormones if we need, and the preconception testing that I mentioned. This can be just general health, possibly genetic screening. So many times we can do ultrasound and blood work on the same visit. And even if we're going to do the tubal test, it's often possible to do all of those around the same time. The hysterosalpingogram is the one that's cycle dependent, like that kind of has to be done when the bleeding is finished, but before ovulation. But the other tests can really be placed almost any time in the cycle. So, we always try to be efficient with everyone's time and resources, of course. But I know too, in this era of COVID and really trying to minimize the times you have to go in and out of any clinic, we're really sensitive to that as well in terms of making sure we can be as efficient as we can. Not every patient has been trying for pregnancy. So just a reminder that we do preconception assessments and counseling. Like if someone wants to come in and just learn more about their egg supply and where they are in terms of their fertility window, we can do fertility assessment visits. We see patients who are interested in egg freezing. We see LGBTQ, family building, like how do we really, work towards our goal of parenthood together, and single parenting. So there's just lots of different options. There are many ways to build families, and that's all part of what we do at SRM. So also know it's not that you have to have been trying for a certain amount of time to come to a fertility clinic. You can come for any of these additional reasons as well. We're really trying to also expand our focus on wellness. We know that obviously this is important on many levels, especially I think in the realm of fertility. So we are kind of building a wellness program of our own that's going to be rolling out soon, where we're going to be focusing on nutrition, exercise, mental health, all these things. We have the ability to refer patients to an excellent fertility nutritionist. And we even have a program through her called Food for Fertility that is like a structured program where we do kind of, I think, 6-week stints where it's, again, all through Zoom these days, but kind of cooking together, sharing the journey together. I think that can be really helpful, whether someone's trying to gain weight, lose weight, or doesn't need to gain or lose weight, but just is really trying to have as much focus on nutrition as possible. We have mental health providers that are part of SRM that can definitely do counseling, since we know even getting to the point of maybe coming to a fertility clinic can be a difficult process. And we just know that there can be times where it just gets really stressful. And so we want to have the ability to, this is whole mind, body, not just sole focus on all the hormone levels and all the data and all of that, really supporting the person and the patient. So we have mental health providers. There are acupuncturists that also practice in their private practice and have services for our patients at SRM. And we have also built a PCOS wellness program. So that has been built by our nurse practitioners who are outstanding. And this is up and running, which I think is an excellent addition to our programs. And these are just, some of the, when we do a lot of surveys to try to figure out how we can continue to try to do better. What are the things that were good about your first visit? What are some of the challenges? What can we improve upon? What have you been thinking about, during this journey? So some of the things that patients tell us they wish they would have known, sometimes in everyone, I think there's so many well-intended people surrounding patients that are struggling with fertility, but you hear a lot. There's a lot of you hear this and you hear this and you see this online. There's some good things Dr. Google has to say. There's some things that are overwhelming. But I think that, at any point, if you just feel like you need more guidance, that's probably the time to come to a fertility center, because we can hopefully just give you more information, educate. Maybe it's not time to do a whole bunch of testing yet, but maybe we can really give you some pearls on how to try in the most efficient way. And that might lower your stress and just make the journey better for you. I almost always say this at every visit, that there are many ways to build a family. And sometimes I think patients may not be aware that there are things like donor egg and donor sperm and donor embryo, and that might not be what every patient needs, but these are definitely ways to build families and definitely things within the scope of our practice. I think having support around you is always really important, and we can give more information about resources in the community. We're really trying to focus a lot on this wellness plan as well, this wellness program, to be more supportive. Mental health is a big part of it. I think sometimes fertility challenges, which not everyone seeing us has a fertility challenge, but it's one of those times where we're not in control of everything. And that's true for the provider as well. And I'm kind of a control freak, so that's hard for me to give up too. But sometimes that, I think of the energy pie of any kind of treatment, and fertility treatment, I know, draws heavily from that emotional component of that energy pie. So that's why we really try to do as much as we can for support. Sometimes it can take a little longer, I think, than people are expecting to move through all the processes. And our goal is to try to streamline things as much as possible. And I think that's why if you have all your paperwork in and ready, and any tests that you've had done, if it's able for us to get a look at those before the visit or to have ready for the visit, it's just going to kind of help us move through that process even a little bit more quickly. We also, just reminding that we also follow patients in the early part of pregnancy. So once our patients are pregnant, we do their first and sometimes second ultrasound and really try to make sure that they have a smooth transition back to their OB provider. The pandemic, I think it's a good time just to remember and talk about what are we doing the same and different because of COVID. It was true at the very beginning of the pandemic, we did have to stop many of our services for a period of time. This was just because it was so new and it was unclear whether there would be enough PPE for the frontline providers. And so we did stop and slow a lot of things down. But really by, even the later part of April, we were really back to adding a lot of our things back. So at this point, we're back to our full volumes. We've changed a lot of things, like doing everything we can remotely, just to keep everybody safe as possible. And to be honest, a lot of patients have liked this because it's sometimes easier to not have to carve out the time to drive and park. And depending on where you live, even though we have a lot of locations, there might not be one that's still super close to you. And this just allows there to be, I think it's easier to kind of plan visits and have follow-ups in some ways. So we're really doing everything we can do remotely, but we are doing ultrasounds and testing and all of our treatments as we normally would in most cases. we're not having partners in rooms for things like ultrasounds and procedures and even things like embryo transfers, which is different. And, our goal is to really, once things seem a little bit safer, once maybe most of the population is vaccinated, once we see the rates lower in our community, just know that it's a priority for us. But our main priority is trying to be able to keep everybody as safe as possible. These are just sometimes patients will ask, like, what are some good places to look for information? There's so much out there. And, we have a robust website. There's a lot of good information. ASRM, which stands for the American Society of Reproductive Medicine, like, as physicians and providers, this is where we go to look for evidence-based medicine, to look for newest recommendations. This is the big meeting we attend every year to get our updates. And when you go to their website, there's like for providers and for patients. So there's a lot of really good information there. Resolve is a national fertility advocacy group, and there's local chapters, and there is one here, and that's a real good place too, where you can, you can connect with patients, you can learn more about different support structures. So I think that can be a really good resource as well. And then ACOG, the American College of OBGYN, more general like OBGYN things, but there's also some good information about fertility and about pregnancy things. So that's also a really good resource. So these are the ones, like if I'm getting online to look for something, it's usually going to be one of these sites. And these are ones that we recommend to patients as well. So I think that is most of where we are, and lots of chats, and this is great. I'm going to kind of go through, I know when I was doing the talk that I wasn't able to see a lot of the chats, so let me kind of go through here. For semen analysis, when do we time it? We do have a handout that gives some instructions. So we think that there's probably an ideal time of abstinence of about 2 to 3 days. So not much shorter or much longer. We feel like, I think sometimes there's a thought of, well, if you wait a really long time, will you just have better counts? But then sometimes the movement scores aren't as good. So in our handout and after the first visit, we'll review this with you, but usually about 2 to 3 days of abstinence for most is going to be optimal. In terms of like testing and treatment, so I feel like we usually need like 1 menstrual cycle to get the testing done. And that's because particularly that uterine tubal test falls, usually, after the period before ovulation. Most of the other tests we can do at other times. So I feel like it often takes about 1 cycle to get all the information we need to properly discuss the options. And when I have a new patient visit, my goal is to have that visit, to get the testing done, to plan the follow-up ideally before then the next cycle begins, so we can kind of have an action plan for that month. Now, depending on what treatment though, if we're doing something more basic like oral medication, things like insemination, we can, pretty much be ready that next month. If it's more like IVF, that can take maybe another month or 2 to begin. There are more complex treatments like donor sperm. Sometimes it just takes a month or 2 to get through all of the testing that the FDA requires, have the sperm here. Donor egg can take more like 3 to 6 months, depending on whether we're going to go with eggs that are already frozen that we have, whether we're going to be harvesting new eggs in a donor. And then things like gestational carrier can take a little bit longer than that, just because there's more moving parts. So it depends a little bit, but for more basic treatment, which is where many patients start, I would say usually within the first month or 2, we're kind of on course with the plan. Yes, it is definitely possible to do diagnostic testing elsewhere. Pretty much all these tests are ones that any clinic could do. So if you live like in Fairbanks or you live, in Montana, we, a lot of times we'll make a list of like, here are the things that we would ideally like to have. And almost always we can organize with the local clinic if that is easier. And almost all, I've cared for a lot of patients in Alaska over the years, and almost all we do the testing there and then review the results. For BMI, so just some of the things for BMI. So, and the BMI, where these kind of questions and numbers come from is that as an outpatient surgery center that's not attached to a hospital, there are different regulations than, say, an operating room in a hospital. And, when we do our surgeries, whether it's like fibroid removal or polyp removal or an IVF, we do a surgical procedure to harvest the eggs, which requires anesthesia. We're doing it in this outpatient facility. So the rules for outpatient facility are the BMI needs to be under 40 for us to be able to proceed. Between 35 and 40, we do an anesthesia consult just to make sure that we think everything is safe, and typically patients are approved. Above 40, we would need to ideally shift the BMI less than 40. If that's just not possible in the near future, we do have a program through OHSU in Portland where we can kind of prepare patients for IVF, and patients can go there for their harvest. So we do have some options to consider if our BMI is above 40 and it just seems like it might be challenging to get it under 40 by the time we need to do IVF. In terms of BMI recommendations, the data, and this is hard because a lot of the data is in IVF, and so that's hard to extrapolate sometimes, in terms of non-IVF. As I said, we do really ideally need the BMI to be under 40 to be able to do the surgical procedure for IVF at our center. And then for IUI, we say ideally we would like the BMI to be less than 50 to begin that kind of treatment, but we take it case by case to really, always consider the patient's story. FSH cutoff for IVF, we don't have a hard cutoff. Some of our cutoffs, I guess, would be if we're maternal age 46 and above, we do not recommend IVF with own eggs because we haven't had a successful live birth in that age group. We would still offer IVF with donor egg to the age of 50, but would not offer IVF at age 46 and above. In terms of FSH, so when we're counseling patients about IVF, we do look at the FSH and at the AMH and at age group, and all those things we do individualize for the patient. And typically when we have that data, we can quote a success rate. Part of it's based on age group and part of it's based on these egg supply tests. And then we just talk about that together. And, I think that patients often then are more directive in what we do, because if we really feel like the FSH is so high that we are very unlikely to make it to egg retrieval and very unlikely to get enough eggs, and if we think that chance is less than 2 or 3%, patients may choose or not choose to take that chance based on the expectation. So we don't have a hard and fast cutoff. I would say we take it, individualize it for every patient. And we put a little bit more emphasis, I would guess, on the AMH than the FSH, but we do look at them both together. Our urologists do sperm aspiration. So that's a really great thing. We have 3 urology providers, 2 of whom do surgical procedures at our surgery center, and they do different kinds of sperm aspirations. Sometimes they can do a basic like percutaneous with local. Sometimes they have to do a more involved sperm aspiration, and obviously based on the patient and the story, they would talk about that. But yes, that is something that we can do at SRM. I have definitely, if you get pregnant naturally before the appointment time, and I've definitely seen this, and yes, you can keep your appointment because we can talk about, maybe there's been a history of miscarriages and we want to do what we call our TLC plan, where we do early HCG levels and we do an early ultrasound and we do a weekly ultrasound until 10 weeks. I know that the first several weeks of pregnancy can be the hardest because most of the time it's not till 8 or 10 weeks until most OBGYNs, will offer their first appointment. And, I know there's a lot of kind of worries during that time, especially if the journey has been difficult. So yes, you could keep your new patient appointment. We can talk about your story so far. We can offer early monitoring. And if all's going well, we can happily help with that handoff back to your OB provider. Let's see. I'm looking at the next one, trying to conceive, analysis showed parameters in the lower range. This a little bit individualized. So this one here about the semen analysis, I mean, sometimes there's lots of different parts, like it may depend on the age of the patient and some of the other testing that's done. Sometimes if it's borderline, those are still cases where we typically start with insemination first, with IUI first. And sometimes if a couple's leaning toward IUI, I don't know if it makes sense to repeat another semen analysis because each time we do an IUI, we get another semen analysis. So it's kind of like over time, we're getting these updates and we're actually doing something more proactive to try to conceive. So this is all about choice. If you're thinking like, we're just not really sure we want to start insemination, yes, like maybe it would be helpful to update. But to be honest, sometimes we even recommend IUI when the semen parameters have been totally normal, if a couple's been trying maybe more than a year or so, because we say, still IUI is going to help get the egg and sperm closer to each other. And that's kind of the hallmark of almost all fertility treatment, is to favor the odds. So I still think even when the counts are normal, sometimes we think about it. For new, so in terms of IVF, I mean, there's the part where, is there a wait list for IVF patients? You have to have the first visit. We have to see if there's any testing we have to update. And then we kind of have to see about our availability. We do book out sometimes a month or more for standard IVF, and sometimes closer to 2. Our goal is to not book out more than 3 months, but sometimes it can be even 2-ish months if we're planning more specialized kind of IVF called IVF with PGT, which stands for pre-implantation genetic testing, where we test embryos for chromosomes. So I would say, not a waiting list for new patients. We would say when we have availability, we will schedule that. I think if you already know that you're probably wanting to do IVF, just mentally preparing that it could still be 2-ish months before we might be doing the cycle, depending on how long it takes us to get the testing done and our availability in the lab. We never want to overload the IVF lab because we want the quality of the care to be as excellent as possible. So it just kind of depends too a little bit on what kind of cycle. In terms of vasectomy reversal, I mean, I usually think it's a good idea to meet with your urologist, because they're going to talk to you about the pros and cons of the procedure. There's basically, you could do vasectomy reversal, you could do a testicular biopsy and plan to do IVF. Those are like the 2 main pathways. I do think that most of the time the decision depends on both partners. So it depends on age of female partner, perhaps a little bit on egg supply. So I think many times it makes sense to start with the urologist, but many times they will also want you to have some testing on female side. And that's the nice thing, that we work so closely together. Like, we're in the same clinics, we can communicate easily. It's not like you're at 2 separate places trying to merge the records. But typically we do a little bit of testing for female partner as well. I think most of the times they do the reversals here at our facility. And that's because of the fact that we're always wanting to freeze a little bit of sperm just in case we need it. And then we can easily do that as part of our lab. They may also have the capacity to do them at other locations, but I think the majority of them they try to do here at our locations. Do you recommend that women under 35 wait for a year? I feel like it just all depends. You'll hear the classic, like, try for a year, but that's not true for everyone. I think 35 and above, I would say at the 6-month mark, it probably makes sense to get more information. I think if they're under 35, it kind of depends too. Like, if your cycles aren't regular, if there is a potential known issue, if there's challenges with having intercourse or timing intercourse, then it makes sense to come sooner. I think if everything my cycles are regular, I can try normally, we don't have any challenges there, then I think you can wait up to a year. But, we're going to be happy to see you no matter. I would say before 6 months is probably early in any age group, but we kind of are more like at the 6-month mark, no matter age group. If you'd like more information, we're happy to provide that. Okay, did I mention resources? Oh, here we go. Is there a way to schedule a call for the financial aspect of treatments? Kenzi, do patients do that sometimes? I feel like a lot of times we have the initial visit, then the financial counselor follows up, but I can imagine that if you have questions, you likely could speak to one of the advisors. Do you want to speak to that one?
Exactly. Yeah. So the standard kind of flow for the financial side of things is, ideally, you definitely want to give us your insurance information if you have insurance at the time of scheduling, so that we can review that before you come in. And then after your consult with the doctor will kind of send us a report of what you're planning on doing. And then we can, gather pricing for that, and then gather information about your insurance benefit and follow up with you with that information. So normally, that is normally done by like phone or the patient portal, just kind of depending on the situation, and a lot of the time depending on your availability as a patient. But you can always, reach out to your financial counselor to schedule a phone call. We're always happy to do that for sure.
Do you consider doing IUI? Yes. I mean, like I said, we will offer both IUI and IVF up to the age of like 45, and then at 46 and above, it's kind of harder, I think, to justify those treatments. And, this is just very individualized. I mean, there are some that want to go right to IVF because they want the highest chance, soonest. They really want to do the chromosome counting for their embryos, which is only available in IVF. They want to see if they can freeze several embryos because they might want to have more than one child, and they know that that might improve their chance. And there are patients who say, we don't want to do IVF. We would like to do inseminations first. So we really individualize this. Most of the time, we will try between 2 and 4 insemination cycles. And this is true in most age groups. And then if not pregnant, if the patient prefers IUI first. And then, I usually recommend, if we're trying IUI, let's try 2 IUI cycles. And then if not pregnant, let's regroup and just review. Like, have there been challenges? Do we want to change anything? How do we feel about the next step? The multi-cycle plan, I know this one's a little specific, so Kenzi, I don't know if this makes sense to talk about right now, or if this would be better to follow up and give individual information, just in the interest of like time, and how that this is definitely where you have better information than I, but what do you think about that?
Yeah, I mean, so just to kind of give like a quick little spiel about the MultiCycle program, we do have a MultiCycle discount program for IVF. It is a bundled package that includes 2 IVF cycles and unlimited frozen embryo transfer cycles. And the cost of that package itself is $25,000. And what you want to compare that with is the single cycle pricing for IVF, which is $15,000 per IVF cycle, and then $4,000 per frozen embryo transfer cycle. So it definitely is a discount if you end up needing to do multiple treatment cycles. But yeah, I would say, details beyond that, we could definitely talk on like an individualized basis as well, and kind of get more into the nitty gritty of the program for sure.
Great. Thank you, Kenzi. How many medicated cycles do you recommend before IUI or IVF? And this depends a little bit on age group, some of the testing information, but there have been studies that have looked at this. And the thought is, in terms of time to pregnancy, cost effectiveness, best outcome, probably makes sense to try 3 to 4 insemination cycles. And then if not pregnant, that's where for most patients, it would make sense to go to IVF as the next step. FSH, what day do you check FSH, which is follicle stimulating hormone? We don't require this, like we do it sometimes. We give a little bit more, I think, weight to the AMH, which is nice because that can be done any cycle day. But the FSH is ideally done between cycle day 2 and 5. So it's called the day 3 lab. There's a little bit of wiggle room, but usually between day 2 and 5. Kenzi, how much does the initial consult cost?
Yeah, so the initial consult for that hour-long visit with the doctor is typically $300, okay, if not covered by insurance.
And does medicated IUI have a better chance? It depends. So I think for patients under the age of 35, there is not data that doing medicine with IUI improves the chance, provided menstrual cycles are regular. Of course, if they're not regular, we're always going to be recommending medication regardless of age group. But for those who have regular menstrual cycles under the age of 35, there is not real data that adding the medication increases the chance. 35 and above, there is data that doing them both together probably is more effective. So we still talk about it, and there are patients that are in the younger age group that still want to do medicated IUI, and that is fine to do. There are some risks in terms of increased risk of twin pregnancies, some side effects from the medication. So that's why we usually go unmedicated. There are times where we really, 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 really worry about twins more, like they've had an early delivery, they have a shortened cervix, they have a medical issue where a twin pregnancy would be very risky for them and babies. And those are times we may more strongly recommend the non-medicated. Can you speak to the egg donor program and fertility? So this, this one is probably one that is a little bit broader, but we do have a very robust donor egg program. We have the ability to, we freeze eggs at SRM. So there are eggs that we have frozen, and we have some packages for that option. It is possible if patients prefer fresh eggs, we have a 12 fresh egg program. If we do not have a donor that is the right fit, we can work with agencies to kind of find that right fit. We are doing mostly embryo creation, meaning we would thaw eggs, or if it's the fresh egg option, we would fertilize, and we would make sure that we have at least one candidate embryo before we have patients, start medications to begin the process for transfer. And we find that that just is preferred, because in the rare cases, if we didn't have an embryo available and somebody had been on medications, that can just be very overwhelming. So we do majority embryo creation, which is working really well. We have frozen egg, fresh egg option, agency option. And benefits, I think, it just depends on the plan. There are some plans that cover donor egg. Even then, some cover like not the egg part, but the treatment part of the cycle. We do have a multi-cycle plan with a refund for donor egg for those who don't have insurance benefit. Again, Kenzi, do you feel like that might be a bit much to talk about now, or what do you think?
Yeah, I mean, just to talk about like fertility benefits in general, we'll obviously review that with you once you're an established patient. But if you're wanting to get an idea of your specific benefits ahead of time, I would recommend just calling your insurance company and asking if you have fertility treatment benefits. And then if so, from there, you want to ask, like, is there a lifetime maximum? Are there any plan exclusions? And if you ask them some follow-up questions like that, they should be able to give you more details.
And then for patients with diabetes and PCOS, yes, I mean, anyone I think that has diabetes requiring medication, we would definitely want to either have a maternal fetal be managing that part and aware and super proactive with diabetes profiling, or med endo, and we would really hope to have all recommendations for them, be following all the recommendations, work closely, and then really facilitate that handoff in early pregnancy. Some OBGYNs are very comfortable managing diabetes in pregnancy. Just kind of depends. Some will always defer to MFM or medical endocrinology, and some that's in the scope of what they do. But we would, we're real careful about really wanting to make sure everything is optimized leading into pregnancy so we can have a healthy and safe outcome. Is it possible to do a sperm retrieval? Yeah, if we are doing a sperm harvest, like a testicular biopsy sperm retrieval, it's always going to be with a plan for IVF. It's a very good question. I get asked it often. And I can see how you would wonder about that, but we're never going to have the amount of sperm we need to be able to do IUIs. It's just when we're doing a biopsy, it's a much smaller volume. So if we're doing the biopsy, we're planning for IVF. And for some, they like the reversal idea better because it might be more open-ended, because they could see how things look. Maybe they could try IUIs first. If not successful, they could still do IVF. But with testicular biopsy, it's always going to be IVF. Limit for A1C for diabetics, we really, really like the hemoglobin A1C to be less than 7. That's usually our goal before we would start fertility treatment. In terms of, we're getting a little close, so we've got a couple more minutes. Describe the initial diagnostic testing. So usually patients would come in, and with this era of COVID where we're trying to do most of it at one visit, there would likely be one visit where there would be a pelvic ultrasound, which, is less, I feel like it's not as uncomfortable as a speculum exam. It's a little bit of pressure. Anyone, I think if you've been able to have a speculum exam or have intercourse, that would probably not be too uncomfortable. And that takes maybe 10 minutes or so. We look at the uterus and the ovaries. The blood work, typically we're doing egg supply testing with that AMH hormone, thyroid testing, pre-pregnancy health testing like blood type, antibody status, and then genetic screening if couples want. The HSG, full disclosure, probably is the most uncomfortable part of the evaluation. It is very doable. I think almost all patients are able to do it, but it does involve placement of a speculum. When the dye is moving, that fills the uterus, and there's some cramping as that happens. And as the dye goes out of the fallopian tubes, there can be some cramping. The whole test, though, usually takes less than 15 minutes from start to finish. And the time the dye is moving, which is the uncomfortable part, is usually under 2 to 3 minutes. So thankfully, it's pretty quick. We do have patients usually take ibuprofen like 30 minutes before, and that really helps with the cramping. But it's the kind of discomfort where it is crampy when the procedure is happening, but it tends to dissipate pretty quickly. You can drive yourself to the visit. You can drive yourself home. We don't give anesthesia, that kind of thing. I think the average age of the patient, I think the average age of the patients we see at first visit is like between 37 and 38 years old. So we are seeing many patients above the age of 35, but we see patients in all age groups. So I would say I would not let that, deter you at all, whether you're younger or older than that group. I think there's place for every age group. Yep, multi-cycle information more on the website. Oh, so, okay. So if to be a donor. So if you're a donor, there's a pretty long process of screening, and that can take a couple of months. Egg supply testing, genetic testing, screening, family history. So all of those things can take a couple of months. And then for patients who are accepted to be a donor, then we get through the process of, being ready to kind of begin treatment. And then I think, we could, Kenzi, I believe there is a future discount for all donors in terms of if they need for future fertility treatment. Is that true?
Correct. Yeah. Yeah. So if we have a donor who ends up needing to do fertility treatment themselves, we do have a discount that we would offer.
Okay. And then family balancing. So, when we do IVF and we're counting chromosomes, we will know the sex of the embryos. And that is information that couples, of course, can have. It's their information to have. If a couple comes in, they don't have a fertility problem and they were simply wanting IVF for family balancing, that's not typically in the scope of what we do at SRM. Every practice is different, and some do, and we can direct patients to those clinics. If there is a need for IVF and there is a need for PGT to count the chromosome, we are always going to disclose that information. And if there is a preferred sex for first transfer, that is allowed. But we wouldn't recommend doing the whole process just for the purpose of sex selection. If you have infertility benefits, I think this one's a tough one, because every plan's different, and some are a greater before where you have to do IUIs first and then you can do IVF. Some are like, here's your amount, you can use it however you want. Some have a number of smart cycles. So I think probably that's going to just vary, and we'd have to individualize that based on the plan. Would you agree?
Exactly. Yeah. Yeah. That's definitely plan specific.
Hey, Amy, this is Marcy on the back end here. You have one more question. Do you have time to
just answer this quick
question? Okay, good. And then we'll just wrap it up.
If we do if we're doing an egg harvest and we're planning to freeze, we do the egg harvest. The period comes about a week later. We're freezing the embryos about 5 to 6. So that's kind of happening at the same time. And then it kind of depends. If we're doing chromosome counting, it's going to be another 2 weeks before we know the chromosome information. We have to wait then for the next period. So sometimes it could be like 4 to 6 weeks from the time we do the actual retrieval until we're doing the transfer. We also have to be at the right time in the menstrual cycle to do the frozen embryo transfer. So I would say it often takes at least 1 and sometimes 2 cycles, in between. But our goal is to move forward as soon as we have the information. We don't like to sometimes be too far in the planning of the frozen embryo transfer until we know we have a candidate. Because if we don't have a candidate embryo, maybe the next step is talking about additional retrievals. But we would work as quickly as we can, because we know that everybody really wants to proceed as soon as they're able. Great. Well, thank you, everybody. I do have a patient coming up, so I probably have to sign off for now. But thank you so much for taking the time. You had a lot of really excellent questions, so I appreciate that. And we hope to see some of you. And if you have any questions or concerns beyond of what we could talk about today, we're happy to follow up with you, whichever way makes sense.